Thanks very much, Kelly, and good morning, ladies and gentlemen. It really is a privilege and honor for me to be here with you. And I appreciate the efforts of the Sarcoidosis Foundation Research with Ginger and Kelly and Maggie to have organized this and reached out to me a few months ago to see if I would co-sponsor this with the University of Washington. And I quickly said yes, and I've been doing the Sarcoid work for quite some time along with the area of field of interstitial lung disease. And it reminds me that a few years ago we had a similar patient education conference for interstitial lung disease and pulmonary fibrosis. This is an extremely important way of interacting and getting in touch with one another and discuss freely in terms of the complex topic of interstitial lung disease, especially the sarcoidosis aspect of it. And I'm pleased to recognize many of the faces in the audience that are familiar to me. I have had the privilege of seeing them in my clinic very recently, and I was very impressed with Karen Russell, who gave a very, very nice talk in terms of relaxations, meditation, and what is meditation. And meditation is really a way of concentrating in whatever you're focused on, and that's at least to me what meditation is. And in fact, I do take at least minimum of 5 minutes or 10 minutes focus time of meditation, and I have a little meditation room in my home, and so I do meditate every day, wherever I am, as Karen Russell says, when you're online, when I'm on plane, for example. Believe it or not, I came just a few hours ago from Milan, was in a conference there, an advisory board meeting, and I learned about one thing. It's a brain to gut axis, and people ask, is there a brain to body axis and brain to lung axis? There are actually brain to gut axis in terms of lung microbiome, which is an infectious concern. That there is an increasing awareness of etiology of complex diseases. So using infection as, because our body is full of germs and viruses and fungus and bacteria. So there is an incredible interest lately in terms of lung microbiome or microbiome of the body, which sarcoidosis I also need to get into, have not yet. We'll talk about it a little bit more. So therefore, I am very much a believer of mind controlling the body, and I have also many patients who have proved to me wrong from a scientific standpoint. So yes, science understands or helps us to understand and provoke more questions. The more we know, the more we don't know, and so that's in a nutshell of where I exist, and I'm very privileged to be an integrated part of the care for patients, especially with sarcoidosis as a multi-system disorder. As you can see, yes, I am privileged to be the director for Center for Interstitial Lung Disease, and a program that's called Interstitial Lung Disease and Sarcoidosis program as well. As you are aware, there is really no quote sarcoid expert. Who is a sarcoid expert? Okay, so sarcoid expert is it turns out that many people with sarcoidosis have it in the lungs, and in the lung it is called interstitial lung disease, and therefore interstitial lung disease, sarcoidosis is an integrated part of it, and some ILD experts become sarcoid experts as well. And then sarcoidosis become an extra pulmonary manifestation, and some sarcoid experts prefer and willing to be an overall sarcoid expert. There is no fellowship for sarcoidosis, and it is some people with internal medicine are sarcoid experts as well, in ophthalmology and neurology. And so this is a very nice structure that the Ginger and Kelly and Maggie have put together in terms of bringing the multidisciplinary discussion or multidisciplinary experts. So what is sarcoidosis? Okay, believe it or not, it was actually back in 1875, which was described as a skin problem, and then there was a guy called Cecil Beth who described it in the lungs or in the chest. So by definition, it involves multi-system. So sarcoid is not one particular organ system. It is a multi-system. So basically it is a body disease and a mind disease. Histologically, we characterize, histologically means under the microscope, we characterize it based on very confined microscopic features in the absence of infection, tumor, and environmental exposure. So it is extremely important for the physician confronted with the patient with sarcoidosis to be familiar with what could be causing features suggestive of sarcoidosis. So therefore it's a multi-system disorder of unknown cause. And like many diseases, we don't know what causes. For example, rheumatoid arthritis, we don't know what causes. We don't know what causes diabetes. So for many many chronic diseases, we do not know what causes it. So, but anyway, whenever a known etiology it brings in a flavor of loss of research, and also brings in a flavor of uncertainty, because, well, you really do not know what you're dealing with. But we actually know a lot in terms of the manifestations. So it is characterized by an immune disorder or immune problem. And so some people think it is an autoimmune disease. And so some people with rheumatological and autoimmune background feel that they are reasonably good expertise, because there are some immune functions like what we call T cells or what we call antibodies, and those are implicated in the pathogenesis, meaning the causing, contributing, or mechanism pathways to cause sarcoidosis. And lungs, as I said, are frequently involved and are often seen by pulmonary dots. So since pulmonary sarcoidosis is this spectrum, as I told you about experts in sarcoidosis, it challenges clinicians in all fields. It is in fact a great imitator. It affects so many diverse systems, mimics so many infections, mimicked by so many, and there's so much of a heterogeneity involved in terms of its unpredictability. What I as a sarcoid expert, if you will, but not all symptoms that patient with an established diagnosis of sarcoidosis is sarcoid associated. And that's one of the things that I find that patients do. Well, I have sarcoidosis, therefore my symptoms ought to be, for example, the fatigueness is concerned, so therefore it has to be. But as what I try to do is try to find what I think could be contributing for fatigue, for example, like hypothyroidism or sleep apnea, which may be unrelated to sarcoidosis, but may be the primary symptom of a patient with sarcoidosis. So not all symptoms that patients should you experience just because the fact that you have sarcoidosis is sarcoid related. So this is a cartoon to simply give you a feel that sarcoid involves from top to the bottom, including the little toe, including hair follicles, including the scalp, including the toenails, etc. So sarcoid is really, by definition, multi-system. So it is really a challenge for an internist to become a sarcoid expert. Long time ago, this was going back to the early 60s, and this is really still the hallmark, and people who do it, and I have done epidemiological study, they list as the percentage of the organ involvement in sarcoidosis. As you can see, lung is involved in 95-100%. By that it means, it doesn't mean that the patients with sarcoid have lung symptoms. By what it means is, if we take 100 patients with sarcoidosis who happen to die of something else, and if we were to do autopsies, that we would find sarcoid-like lesions or sarcoid lesions in the lung or in the lymph gland. So that is basically a histological involvement, not necessarily a physical involvement. So you can see lungs are topmost, lymph glands are topmost, and skin comes the top three. And erythema nodosum is another lesion, which is, we'll talk about that a little bit. And so we can see the incidence of the manifestation depending on our listed there. And the symptoms, therefore, are involved with the organ involved. So a long time ago, this has not been reproduced, but this was published in 2001 by one of the colleagues of mine called Robert Bachman in Cincinnati, who led a case control study sponsored by NIH, which was 736 patients in sarcoid who had a new onset diagnosis expressed by histopathology. 10 centers, all 10 centers, all of them had sarcoidosis by sure, and women had a higher incidence of high neurological erythema nodosum, and men had a higher incidence of high calcium levels in their blood, and black subjects had increased skin involvement, eye involvement, liver involvement, and in my vast experience, it's also sinus involvement that the African American patients get involved. So the age distribution is shown clearly here. It peaks at the third and the fourth decade, and it's not a disease of older population, although sarcoid does manifest, can manifest in an elderly person as for 70 plus years of age, and I have diagnosed sarcoidosis as a first manifestation in a 75-year-old person. So distribution of cases by sex and ethnic origin is shown here. Clearly it is, at least in the United States, it is a preponderance disease among the dark-skinned people, among the African American population. And so here is also the white and black as a graphic way, Caucasians being white and the African American. You will see that the skin manifestations are much more, the bone marrow manifestations much more, lymph gland manifestations much more among the African American, especially in terms of the women is concerned. So again, this is the 1963, I showed you that lung involvement was high, and in a prospective database in what we call the ACCESS study, you'll see that the lung involvement is 95% and skin involvement is 15% and lymph glands is 15%. So that has been clearly shown over time to the point that there's no particular reason to reproduce this study, and therefore there has been no newer data in terms of the epidemiological distribution, so to speak. A few years ago, I had the privilege of working with a pulmonologist from Spain who came to spend 1 year with me, and so we did a comparison of how the distribution of the epidemiology demographics was among the Spanish people and among the Northwest United States, because here in the Pacific Northwest we have a geographic distribution of predominant of the white population, if you will. And so we had some interesting observations made that the Spanish people had much more systemic manifestation as opposed to the people with in the Pacific Northwest. So maybe they meditate more in the Pacific Northwest and have much less symptoms, I don't know. So these are the 7-6 newly diagnosed matched case control paired questionnaires were involved with occupation. And what was interesting is that if a person has an agricultural employment and if they have been exposed to pesticide, there was an increased association of sarcoidosis. So therefore, I've seen many patients in the region in the Pacific Northwest, in the Wenatchee area, in the Yakima area, with agricultural pesticide exposure, and goes along with that because what we call odd risk ratio is a risk probability of a patient having sarcoidosis is higher if a person happens to be working in an environment such as agricultural pesticide. So work environment is very important. We go into the environment, details exposure of mold, fungus history, because they can cause granulomatosis problems. So the results is, the other thing is, average smoking history, cigarettes was less frequent. In a way, it's ironical that in other words, if you smoke, it is less frequent. I don't know what the real pathogenesis is, so I'm not going to be an advocate to say, all right, nobody smokes cigarettes, okay? So no, because it turns out that the average smoking cigarette, that doesn't mean that the sarcoid patient with the cigarette smoker is going to have less manifestations. So it simply was an epidemiological study that it appears that smoking happened to have a protective effect. I don't know why and how. There has been no pathogenetic explanation for this. So if you look at the prevalence of the intrathoracic sarcoidosis per 100,000, you can see that there are similar incidences in Denmark, New York, Sweden, and Uruguay. These are the prevalence. Prevalence means any given time how many patients are diagnosed or having sarcoid. Incidence means how many people newly diagnosed. If you look at the prevalence of sarcoid in terms of the highest country estimate in single being Greenland, so this is based on the many countries, Sweden has the highest. So if you, it's an ironical way, if you have blue-eyed blonde coming from the Swedish or the Scandinavian countries, you have the highest sarcoid prevalence and incidence, and if you're an African American, you also have a high incidence. And among the Japanese, the incidence and prevalence is less, but cardiac sarcoidosis is much more among the Japanese. So the prevalence of sarcoidosis in the United States is the incidence is 13.8 per 100,000, and the prevalence is about 50 per 100,000 population. And the incidence and prevalence is similar in China, India, United States is shown here, and in India, where diagnosis of sarcoid is very hard to make, or because of tuberculosis, because sarcoid mimics tuberculosis, and among endemic areas where tuberculosis is very high, the diagnosis of sarcoidosis is very difficult. And recently, I was also privileged to be an advisor board for the Indian patients with sarcoidosis and tuberculosis, how to differentiate, and we wrote this in the sarcoidosis journal not too long ago. So the lung involvement is physiologically, we call it a restricted disease. People are not able to take in deep breath, but there is a coexisting airflow obstruction similar to asthma. Pleura, meaning the outskirts of the lung covered by a membrane called pleura, can be involved, and these people get chest pains and these people get fluid accumulation, but it's less common. Acute manifestation is what we call a Lofgren syndrome, which means a constellation of symptoms and signs. These are people who have lymph glands in their chest and have fever, including chills, mimicking infection, and severe joint pain and swelling of the ankle joint, along with discrete skin nodules, and very painful. So this is called Lofgren syndrome, and if we have this constellation, we think that we do not need a diagnosis to be confirmed by biopsy. So if you take all comers, so sarcoidosis, as I said, it is involved in the lungs, so therefore there are stages in chest X-ray. One, you can have a completely normal chest X-ray and get that sarcoidosis. You can have it just in the lymph gland, you can have it in the lymph gland plus the lung, or you can have it only in the lung without the lymph gland. So these are stages that a guy called Scadding came up with in the early 50s in England, and this still holds true based on the chest radiograph, but this staging has not been revised after the advent of more sensitive imaging such as the CT scan of the chest. But generally speaking, you can have a normal chest X-ray and still have sarcoid. You can have an extensive degree or extent of involvement and be asymptomatic. This particular staging is simply a spot check staging. It doesn't mean that in order to have stage 4, you start out with stage 1, but it makes simple logical sense. You start out with a normal well-being, which means normal lung, and then have a stage 4. So there has been no data to say that in all patients who present with stage 1 will end up with stage 4. So that's the fact of the matter. So this is what we call a stage 1 with lymphadenopathy, and this is lymphadenopathy, and all the white shadows there are the scarring changes, and this is absolutely no lymph gland between the white big structure in the center is the heart. These are the shadows, if you will. I'm looking for a pointer. So this the white structure, this is the heart, and the lymph gland would be here, and these all white structures would be the scarring in the lung. And this is a stage 4 extensive. The lungs are distorted, and there is a lot of scarring in the upper portions of the lung, and there is some air trapping. We call it air trapping based on hyperlucency, and this is and the lung is low lung volume. So this patient could be totally asymptomatic, believe it or not, and be functional. I've seen many patients with this extensive sarcoidosis and have no symptoms. But on the other hand, they could also be symptomatic and then require supplemental oxygen. These are the kind of patients with lung sarcoidosis need to be considered for lung transplantation. CT scan, of course, is very sensitive because it picks up the images, and here shown is a very typical CT scan. The CT scan here to orientate you, this is a person lying on the back, this is the vertebral body, this is the back, this is the front, this is the sternum, and this structure is the shadow of the heart, and adjacent to that is the lung. This all the black structure is the lung, they have got air in it, and this is white structure called scarring around, almost like hugging the proximal airways, and that is a very characteristic feature of sarcoidosis. And we call these little structures nodules, which are there around here, which may not be as seen in the light here, but these are what we call a nodular upper lobe infiltrate. So again, I've shown you this, that the more lung involvement with the parenchyma, we call it parenchyma of the lung tissue, the yield of the biopsy by going by bronchoscopy and taking a little scrapes of the lining of the airway, you can make a diagnosis of sarcoidosis. But how do you make a diagnosis of sarcoidosis in the right clinical situation? If you have the chest X-ray or a CT scan, and if you do a biopsy, what we call a granuloma. A granuloma is a histological, meaning under the microscope description. So a pathologist looking under the microscope will look into how the cells are distributed and hugging each other and how the scarring is concerned. We call that granulomas, and basically the granulomas are granules, so to speak, coming together with the cells called macrophages and epithelioid cell, and they usually are very typically of the same size under the microscope. There are many disorders causing granuloma, so this is what we would call granuloma. So this is one granuloma, this is one granuloma, and you can see that there's little kind of clusters, if you will, of cells coming together. So this typical feature of granulomas are all uniform size. So if one would measure, this would be one granuloma, this would be another granuloma, granulomas, and these are relatively normal areas. So tight granulomas in the absence of infection and tumor is called is consistent with sarcoidosis. And if you look at the zooming of a higher magnification, you can see that these blue structures are all the nucleus of the cell, and this is what we call granulomas. So you need to have this kind of granulomas in the tissue involved, in the absence of infection and cancer and vascular to call it sarcoidosis to be 100% sure that we are dealing with sarcoidosis. So this kind of granulomas are seen in the tissues. It could be seen in the skin, or in the lungs, or in the heart if we do, or in other involved structures, so to speak. Now, there are other diseases called granulomatous diseases. Now, believe it or not, there is some granulomas here. There is granulomas here, but these are not as tight. So a very, very good pathologist will be able to differentiate these granulomas versus the granulomas of sarcoidosis. So therefore, sometimes it requires a little bit of an expert pathologist who has got a keen eye in terms of differentiating the sarcoidosis. So basically what I'm trying to tell you is, yes, if you have granulomas, it raises the index of suspicion for sarcoid, but not all cases of granulomas are sarcoid. It is a diagnosis of exclusion, so it is compulsorily action on the physician to eliminate infections and other things of the environmental exposure. The lack of specific diagnosis really can occur in about 10 to 20% of patients, even if you have sarcoidosis. So if that comes into the area of expertise, well, really, is it sarcoid or not? So the non-caseating, we call it another thing called non-caseating. What is caseation is what we call a central area of space, which is necrose or dead. Typically, sarcoidosis do not have the caseation. Tuberculosis typically has the caseation, but what we call a caseating. Caseating means the central portion of the granulomas are basically dead, and in that usually have tuberculosis germ. But occasionally we do see caseating granulomas in sarcoidosis, and most of them patients are very sick with systemic problems like night sweats and fever and weight loss. So some known causes, so to speak, of granulomas are environmental exposure, inorganic agents, and there is this berylliosis with nuclear plant exposure, and talc and methotrexate that is often used for sarcoidosis can actually ironically cause granulomas. So also is tumors like lymphoma can cause granulomas, and there are some other autoimmune diseases called granulomas. So therefore it really becomes, in an atypical case, you want to be making sure, are we dealing with sarcoidosis by definition, or are we dealing with what we call sarcoid-like? There is a new entity, a relatively new entity called granulomatous lesions of unknown origin, which is called GEO, or granulomatous lesions of unknown significance. So suggested etiological agents are infections, obviously. Whenever we don't know the causes, we come up with three big things. One is infection, one is genetic, and the third is an environmental actions or environmental interaction. Among the infections, there is one thing called Propionibacter essence. It is a simple bacteria that causes pimples, if you will, and there is experimental models. If you instill the Propionibacter in rats and hamsters, it can cause granulomas with the Propionibacter identification in the lymph gland. So there is some biological possibility to consider antibiotics, so to speak, for sarcoid infection. So inorganic particles like aluminum, zirconium, talc have been associated with sarcoid, and the mold and mildews and exposure with sarcoidosis. Now my particular experience comes over nearly 3 decades now with pulmonary and extrapulmonary. I've had the privilege of seeing about over 1,000 patients. I lose blood loose, but unfortunately I do not have the resource to have a proper database. One of the reasons that we as UW Center, although been very instrumental with management of sarcoidosis over a decade, we do not have the resources to be able to call ourselves a code center or participating at the 8 sites of the Sarcoidosis Foundation. A long time ago we were asked to apply for it, and I didn't have time to apply for it for whatever other reason. So we beg to the pardon of you, we are not considered as a site of excellence, if you will, by the Foundation of Sarcoid Research. But on the other hand, I feel okay to be considered as a sarcoid expert. So what we have an expert is a person who has more experience, basically, right? So therefore, that's what the word expert comes. So if you're more experienced, you're dwelling with it, so you become an expert. So therefore, so an experienced car driver is a person who's been driving car for a long time. So bronchoalveolar lavage, I've had experience with the T cells and comparison of the clinical features. We said that we presented the Warsaw Committee. Cardiac sarcoidosis has become actually my area of expertise as well, and I've had the privilege of working with our cardiologists to the point in the last few months with Richard Chang and that we are organizing ourselves as a cardiac sarcoid expert team or CSCT or something like that we are joining forces to be able to go to a cardiologist and a pulmonary person to be able to have a multidisciplinary approach, perhaps the first of the kind in the country that we will be launching very soon. So, use of methotrexate in patients previously dependent and treatment is emphasis. I emphasize, I need to have an objective evidence of deterioration or, yes, I pay attention to patients, I listen to the patient, but I'm not willing to buy in to say all the symptoms are due to sarcoid unless I have objective evidence because the treatment of sarcoidosis is not without side effects. So therefore, I really need to be convinced that what you and the patient is telling me is really going along with what I know and what others know about sarcoidosis problems. So I emphasize an objective evidence of the need and monitoring the treatment response. So for cardiac sarcoidosis, we have a protocol that Richard hopefully will talk about how we make a diagnosed sarcoid in the heart, even though the heart doesn't have a biopsy evidence of sarcoid. So that's going to be challenging. So the bronchial lavage we did a long time ago, what we call a CD4-CD8 ratio, is just to give you a feeling that a normal lavage can have sarcoidosis. This was 80-some patients that we prospectively saw, patients who were biopsy-proven sarcoidosis, and we looked into the spectrum of the lavage, what we call a lavage, where we instill some saline into the lung by an instrument called a fiber optic bronchoscopy, and we suck it back, look under the microscope, and look into a receptor of CD4-CD8 ratio, which we documented. Yes, if you have a CD4-CD8 ratio of greater than 4, which has a very high specificity for sarcoid, but for a given patient that you could still have sarcoid and have completely normal. So, skin manifestation, any skin manifestation. So even though we were showing here, typically speaking, it can have from anywhere from little teeny down nodules to cosmetically configured. In fact, this is another historical perspective. The first case of sarcoid was diagnosed in a woman called Mrs. Mortimer. Mrs. Mortimer happened to be having a skin problem which was so ugly in her face, to the point that whenever she would come, oh my God, I don't want to touch her. This was back in the 1850s. So it became a disease called Mortimer malady. So nobody wanted it. It's almost like having a stigma of leprosy or something, syphilis or something. So the first skin manifest patient's diagnosed with sarcoid was a dermatological problem with an ugly skin problem, which we now call it cutaneous lupus erythematosus and such. So it can have some anywhere from papules, nodules to plaques, and usually, in my vast experience, sarcoid lesions do not painful unless it is erythema. Sarcoid lesions usually do not itch, usually. So therefore, if it is usually a painless, cosmetically configuring problems, doesn't really cause any major problems in terms of the morbidity is concerned. But people do not like to be seen with lesions, especially over the face, and so therefore it becomes a treatment of choice for cosmetic purposes. So related then now leading to mortality in the United States, this is a nice study. It was a retrospective study based on data gathered from the CDC, and simply to give you that sarcoidosis is unfortunately a morbid problem, that people do die of sarcoid-related problem, and you can see that the majority of patients dying with sarcoidosis were due to sarcoidosis, and other causes in a quarter of patients, and lung cancer and others are all very, very minor. So to give you just a feel for the number of deaths and age-related mortality is increasing in sarcoid in patients in the United States. It appears to be increasing among women as well. And just quickly to go through, because Kelly is standing up and making me nervous. 2 more minutes of my time. And so, but to emphasize that cardiac death is a problem. Sudden cardiac death is a problem, but I don't want you guys to get scared about it. But on the other hand, we're aware of it to the point that there's an increasing awareness of cardiac problems, to the point that cardiologists in the country now in academic centers are getting interested in sarcoidosis problems. So this is just to give you an just in mortality. It happens to be African American, and if you happen to be an African American and a woman, there is an increased incidence of death. and cardiac sarcoidosis. So I think this is just to give you a feeling of multiple causes of death in Caucasians and African Americans. So just a couple of more slides in terms of treatment. I'm not going to talk much about treatment. We can talk it in the panel discussion. So key points is that yes, patients who have pulmonary radiographic stages, asymptomatic patients do not require treatment with corticosteroid, and symptomatic patients with stage 2-3 pulmonary lesion do require treatment with corticosteroid. So we consider additional therapy when a patient does need to be on corticosteroids, and the unfortunate problem is one of the problems that Ginger already said is because of the heterogeneity, we haven't really gotten a good handle in terms of randomized controlled clinical trials to get a feel for which of these drugs work and how much doses of prednisone, what kind should be given. All of that really needs to be worked out. And of course, there are other treatment in terms of the treatment with the Remicade or infliximab. There is a good prospective data that people like Ms. Russell, who shared it, is actually feeling better and stabilized with. So my personal approach, corticosteroid and absolute indications, or if they have eye involvement, or if they have central neural involvement, or if they have progressive lung involvement, or cardiac involvement, especially with arrhythmias problems. And I start out usually with a very low dose prednisone, and in those patients who need to be on prednisone, I shift them to methotrexate. Methotrexate is becoming a widely accepted drug for patients with sarcoid, both lung and elsewhere. So with that, I will leave that, and I think I am in time for 30 minutes. Thank you very much.